This is Healthcare Now, radio's trending now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
This is Trending Now on Healthcare Now Radio, where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Welcome to this special episode recording live from HIMSS26 in Vegas, where I'll be speaking with two guests. First, we're thrilled to have Sandeep Wadhwa, Global Chief Medical Officer at Solventum. And everybody at HIMSS, of course, sees you because you show up on the app as the first page.
Wow, I didn't know that.
Have a nice big booth, so you've got some nice marketing folks going on. So
excellent.
That's awesome. So Sandeep, tell us a little bit about yourself and what brings you to HIMSS.
Oh, sure. I am a physician who's always been interested in population health, and I made a decision early on that I could do that by working at a system level, and so HIMSS is just one of those fantastic formats where you can kind of make a change with one partner and see that kind of proliferate throughout the system. So this is a high energy, love coming here, whether it's Orlando or Vegas, I'm here.
Great. And next year, I hear it's going to be in Chicago. So it's been a while.
Great.
Since it's been out there.
Dealer's choice back to Chicago, always good.
That's right. So far, what's been your favorite part of HIMSS, and has anything caught your eye? Anything surprised you?
I mean, yes. I guess I wasn't expecting to see so much about rural health transformation. And so I was coming in thinking it was going to be agentic AI, Gen AI, and that delivered. But to see kind of rural health kind of get a pretty big representation was a surprise, and a delightful surprise.
That's great. So now, give us a little bit of background on Solventum itself. In case somebody doesn't know, what do you do? Who do you work with?
Sure, thank you. No, we have a leadership role in two very important parts of healthcare. One is we work with regulators and payers on the way they pay for healthcare services, advanced payment models. And we do that with about 16 countries, not only here in the U.S. And so we have a deep relationship with regulators, with CMS here in the U.S., and with the state Medicaid programs on how we pay fairly, accurately for healthcare services, and also how we help to measure outcomes in healthcare. How do we, particularly with a focus on reducing quality defects? We have a thesis that you can measure a quality defect within 30 days and act upon it, and patient safety goes up and excess cost goes down. So that is half the business. Then the other half is working with the hospitals, provider systems to ensure that they're capturing the complexity of their care, that their documentation and coding is complete. And so we have a wonderful relationship between regulators and payers and with the providers on the other side.
Great. And who's hiring you guys to do this?
Oh, well, I mean, we tend to work most closely with the health systems. And so they use a lot of our software for accurate documentation and coding, and that gets part of their revenue cycle mix. And we've been modernizing that or bringing more AI to that solution set. And then we also work with the regulators and the payers themselves. And so they're also purchasers of our services and software.
Got it. And so as you do this work with hospitals and health systems, one of the reasons why you're so good at what you do is because you have these great relationships with CMS and others. Give us a little bit of insights as to what do you think has happened in the last couple of years as the new administration has come in? What's been about the same, and what's changed quite a bit?
Well, I think in some ways the work with CMS has been pretty steady, but I would say our work with Medicaid, which is still the largest insurer or coverer in the country, pick a number between 70 and 80 million. It tends to fluctuate, but there's been an investment, an interest in new models of care for rural health that is very interesting, and again, I was a little thrown off. I wasn't expecting to see that manifest here already as health IT investment, but it is. And I'd also say that what I'm also seeing a lot of interest on the government side is maybe re-looking at how we pay for outpatient care. That there's still a lot of pockets of outpatient care that are paid by cost or by charges. And it's hard to do value-based care if you're kind of still relying on a fee-for-service chassis. And so that area, I think, from a policy perspective, outpatient care, rural health, have kind of been what I've been seeing a lot more emphasis in the past few years.
No, I love that. In fact, you guys do a lot in value-based care.
Yes.
So tell us, what are your opinions about maybe CMS's new access model? And is that truly innovative, or are they recycling some old ideas? What do you think about them?
I mean, these are our next generation ideas. And so my sense is you're always on a journey. And it's always a next version. And so I think some of these models that start to get more mandatory deal with some of the self-selection issues that we saw with earlier versions of bundled payments. So I think that these are steps forward, and they're learning steps forward. And I think I'm expecting good things out of kind of moving towards episodic mandatory participation in different bundled arrangements.
Yeah, but from your perspective, you don't see fee-for-service going anywhere anytime soon because it's still a large chunk. But let's focus on the value-based care side.
Yes.
Tell us, what is the reality? What's working? Talk about ACOs. Talk about value-based arrangements on the private side. What's working and what's not? And pretend nobody's listening. It's just the two of us in a room.
No, I think my sense is that we have models of prospective payment for inpatient care. It's been very hard to extend that model post-discharge, pre-discharge. And so I am really encouraged by a lot of innovation that I'm seeing going on at the state level around moving towards payment in full for a visit. If we can have one bill for one visit and not generate 80 lines, which we do remarkably well for a hospital, and we're moving towards that on outpatient. And so I think that is a very exciting place that I'm beginning to see folks really focus on is let's start, if we can do payment in full for a visit, one bill, I think then you can start to put the building blocks together.
And what do you think is the biggest lack in being able to do that?
Well, the part is the outpatient environment is so complex. People go in just to get a lab, just to get an X-ray, and how you tie that back to a visit is tricky. But I think particularly with outpatient procedure volume growing, we are moving so much inpatient procedures to outpatient settings. I think that's the place to start. This notion of orthopedics has been transformed. Orthopedics, you talk to people 5-10 years ago, how long it took for them to do their knee procedure, their hip procedure. Now, in the morning, walking out in the afternoon. And so I think that as complexity is moving to the outpatient setting, procedures are going to be where we'll start this change. That'll be 60-70% of outpatient care, and I think that gives us a real good footing for value-based care models, building off of complex and even simple procedures.
One of the things I like that you guys do is benchmarking. So talk to us, how does benchmarking and analytics of benchmark analytics help you move into value-based care?
Well, I'm probably even going to talk about some international examples.
Oh, please.
We work with both the Belgian government as well as the Belgian hospitals. And I think the Belgian hospitals have taken a really serious approach to mortality, to adverse events, and to readmissions, and they're really looking at risk stratification. And in that if you're going to ask people to benchmark performance, let's really agree on the complexity of the patient. And so, Shahid, I think that the notion of risk-adjusted, very precise measures is kind of the basis for benchmarking, and then you can the goal isn't zero. I think we're not looking for zero defects. It's risky business. But we shouldn't have higher than expected outcomes. And so I think I've been really impressed with how the Belgian hospitals have self-organized around risk adjustment, setting risk-adjusted expected, and then showing each other performance and allowing folks to drill down. I think there's ways to do this that are self-regulated versus kind of government regulated, and that's one model.
No, I love the examples you guys give outside the States because you have a lot of that experience. One problem you hear from U.S. leaders is, well, those countries are socialized medicine. Well, those countries are smaller than us. Well, they are able to do more because they have more government controls. Are those good excuses? Or can we still learn from them given all those are as facts?
I think there's a lot to learn from them, and I still think I think the area where I do see some of these countries having an advantage is they're able to see care outside of their system. There's still a lot of the care that is associated with an ACO, as you mentioned earlier, with a hospital. The follow-up care could occur somewhere else, and you can lose track of that information. But again, my sense is that's a 20% known variable. We're making improvements. I'm encouraged even upstairs and here around folks who are able to link data. So I think that that's probably the area that I'm most sensitive to. Otherwise, there's enough variation that we see within a population with Medicare, a population with Medicaid, that I think you can still have insights, see the variation, and act upon it.
Yeah, and that makes a ton of sense. So we have about a minute left. One of the biggest problems when you're trying to do value-based care is understanding outcomes.
Yes.
So tell us, you guys have a lot of experience with that, especially outside the country. There are lots of people defining outcomes. Tell us about that.
Well, I think we've taken a view that that quality defects as measured by excess post-acute, post-procedure care is very quantifiable. After even going in for something like a bronchoscopy, 7% of patients after bronchoscopy will end up in the ED or the hospital, and you have variation that is astounding. Where 40% have double those rates. And so I think measuring excess utilization that leads to a patient safety adverse event and excess costs in short windows really gives us an opportunity to improve value and improve patient experience and reduce excess costs. And key to that is obviously getting your risk stratification right so you're not disfavoring folks who take care of complex populations.
That makes a ton of sense. So Sandeep, thank you so much for taking time out of your busy schedule here at HIMSS to share your insightful perspectives with us. So we'll hope you'll come back later in the year and tell us how you're doing.
Well, I wish you a successful conference. Thank you for the time and the conversation.
All right, appreciate it. Welcome back to our live recording at HIMSS26. I'm your host, Shahid Shah. My second guest is Cheryl Pammer. She's Senior Head of Insights at Minitab. Cheryl, tell us a little bit about yourself and what brings you to HIMSS.
Well, I am a longtime statistician, data scientist, and I've been working for an analytics company known as Minitab for 32 years. And I will say one of the areas we work at in HIMSS is we're very focused on continuous improvement. So in the world of patient care, it's actually looking at how we can help you reduce, say, patient falls or improve your emergency department process or anything really related to improving the experience that a patient has.
Great. And who are your customers? Who are you working with? Who normally calls you for help?
Lots of customers. So in general, Minitab works across many different industries, but in healthcare, some of our biggest successes have been some of the biggest healthcare companies in the world. So we've got Johns Hopkins recently had a great experience with reducing the time that it took for patients to flow through their emergency department. We have 8 departments of correctional facilities, their healthcare. So you name it, large, small healthcare systems all around the world.
It is impressive how many different kinds of customers you have. But one thing I really appreciate is, and you'll see this here quite at HIMSS, is everybody understands data is everything. So, some people collect data, some people process it, some people store it. But there aren't that many companies that say, okay, you've already collected it now, it's there. Now, what the heck do we do with it, right? And that's where you said, I think it's a great place to be. So tell us, what do you, I assume you've been to HIMSS many times before. So if so, tell us, what do you notice about HIMSS this year? Anything surprised you? Does it look different? Anything like that?
There's a lot of buzz around AI right now, right? And so we see things kind of go in cycles. And right now, everybody is all excited about AI and how it can help. I think it's exciting to me as a statistician, seeing how analytics are in the forefront of people's minds. But there's also a lot of hype that might not be playing out. So I'm really interested to see where we are, say, 2 years from now. Right? Because we're kind of at the beginning of getting the AI implemented into our healthcare systems, into our decision making, into the work we do.
Yeah. And so as you work with data on a regular basis with health systems, what do you usually see as you walk in? Is data already prepared for analytics? Is it cleansed appropriately? Are the aggregations in good shape? What do companies already have well done? And then what do you do when you come in and say, oh my God, I got to fix all of this up? How does that look like for a typical customer?
Yeah, well, I would say people are far less advanced than in general we like to think, right? And so what I see all the time is everybody thinks that, oh, we're not quite there yet, but everybody else is there. Nobody's there. So it's surprising to me, first of all, how much data is still collected by hand, writing down on, a clipboard.
Really?
It's amazing.
Even in 2026?
Even in 2026. There are a lot of concerns around data, of course, with HIPAA and all the regulations around the world. And so there are also, I think security concerns also keeps data sometimes in silos, where you can get a lot more information by combining, say, patient demographics with, what's going on in the emergency room versus looking at why someone's readmitted. It might take a bunch of data sources together to get a lot of information out of that data. And we have a lot of disconnected systems that make it challenging.
So do you guys help with getting those integrations done first?
We do.
And then so when you come in and you see these silos, you come in, the hospital brings you in or a provider brings you in, and you can actually do the connections and then prepare the records. And on top of that, then do maybe health economics, et cetera, on the latter end. So that first part is what you see a lot of companies doing here. But that last part, the health economics part, and the actual analysis that they're not doing well, is that about where you fit?
And we have become a full-fledged analytics platform. So we are doing everything from the data connections into the analysis. Historically, our company's been around for 52 years, which is, or actually more than that now. So since 1972. So we're over 50 years in analytics. And so a lot of my expertise is on analyzing the data when we actually have it and have it ready. But getting that data ready for analysis is actually, and collecting that data is one of the biggest challenges. And we help with that as well.
Okay. So give us some examples over the last couple of years where you came in and what did you have to end up doing that they didn't know you had to do? Because that's a very common thing is they think they're ready, but in order to get answers out of their data, and they think, oh, well, we don't really need to do this kind of analysis because we can just get an LLM or get an AI and it's going to find our answers for us. How true is that or how false is it?
Well, the problem with LLMs and AI in general is they don't have the full context of what's going on. And so the one thing I've found is a lot of people are doing a good job with visualizations, but if you really want to up your game, you need to look at what drives something, right? So if I'm looking at something like what's causing a 30-day readmission in a hospital, I need to understand what potential drivers of that could be in order to get a prediction at the individual level that, there's a 20% chance this person's going to be readmitted. So now I know I need to follow up with that patient. Well, in order to get that good model, you have to have the right data coming in. And that doesn't happen automatically, right? That's understanding your processes. That's understanding that some data I haven't even collected yet. Maybe I need to go back and collect that data. So there's a lot of information that gets lost when we just go pure AI, because we know the context, right? And we need that context to actually provide good information into those models that can give us great and very helpful predictions in the end.
Yeah, that makes a lot of sense. Then let's assume there are folks who already have done pretty good plumbing and data is flowing. Some of it could be pre-aggregated, but then later you have to do a little bit more.
Yep.
Where do you see the sophistication of people asking the right questions of their data, though? Because assuming you got the data right, there's still the problem of what are you asking it for?
Yeah.
And so how many companies or customers that bring you in know exactly what questions they want to ask, but then you help them with data? Or is it like both things you have to help them with, is help them with data and then explain these are not the right questions?
I love that question, because I would think one of the biggest mistakes people make across industries, not just healthcare, is there's this thought, we've collected all this data, right? It's sitting in Epic or whatever. What can you glean from it? And that's putting the cart before the horse, because we always should have just a problem that we're trying to solve in mind, and then think about the data that supports solving that problem, as opposed to saying, here's all this data, tell me what you can tell me about it. So yeah, great question.
So as you think about people now embedding things like open evidence, AI tooling, they are sometimes able to generate questions from these kinds of systems. So what do you feel, given that you have a lot of customers, especially big ones like Johns Hopkins, is there a set of, quote, standardized topics, questions, etc., that you guys pre-package? Or do you feel like almost every customer you work with is an N of one because they're so different when you walk in?
Yeah, I think both. Everybody's unique, for sure. There are certainly some key metrics, KPIs, that everybody is looking at. And so it's a little bit of both. Everybody's, implementation in emergency room is slightly different. So they might have slightly different challenges. But then, there are some main things that are just commonalities across organizations, right? Everybody's looking at patient falls. The government is requiring in various parts of the globe certain things they have to track. So we're looking at that. I love the fact that we're doing a lot more with health equity now, right? That's a big one. So I would say there are a lot of commonalities. The one thing AI is nice for, and I really like it, is just brainstorming other ideas I might not have thought of too. So I really think that's a great way to say, maybe this is something I should look into.
So we often hear from senior leaders that, why do we need to bring in, somebody like you in order to do analysis when we've got the EHR, it's going to handle everything for us? How do you answer that in a realistic way? Because obviously the EHR is good at what it does. It may even have the data that it needs, but there's a lot more that has to happen. So for those people who think that the EHR can handle the kind of things that you guys do, why is that?
Yeah, well, I would say one thing we bring as an analytics company that's been around for so long is a lot of expertise. So you mentioned, do companies have the same problems? Yes, a lot of them do. So we're bringing in a lot of knowledge around how to solve them and other data they may not have thought of collecting. Maybe we need to add a patient survey into this, and here's how that's done. And, this has worked for this organization. Let's do something similar here. So we're bringing in expertise that can be really tuned to, what a specific healthcare company might need or hospital organization might need.
What are some of the hardest kind of questions that you're being asked to do, where they've asked you to answer some questions, do some analysis, but they just don't have the data and it's too hard to capture? Is there any kind of things that is too hard for you guys to do?
I think sometimes we have to rethink about the problem, because one thing I've seen, and I've been in this business for a long time, we now have a lot more data that's just automatically collected. And I think one thing that's kind of gotten lost is the art of actually collecting data, because we've got this stuff that automatically comes in, but usually it's collected for a different purpose than the problem we're trying to solve. And so I think one thing I've had to do sometimes is, we got to step back and maybe actually do an experiment here to really look at this particular problem, because your data coming in was collected for something completely different. It's maybe not telling the whole story. We're drowning in data and we're information poor. And, it's really understanding there are other ways to get this information. Let's think about the problem we're trying to solve and what information we need to support that problem. Right.
That's a unique insight. So I've been building EHRs and electronic healthcare systems for many, many years. We tend to think, what else might you need? But you're right, for each individual type of use cases. So is there something that comes to mind, a unique story, something that you just worked with a customer with recently that would show that data collection, if you don't do that, it doesn't help down the path?
Yeah, so one that comes to mind was looking at what's it called? ATP. It's basically the cleanliness of surfaces inside hospital rooms. Right? There's nothing automatically collecting that information, but you also have to think about how do you want to collect that? Do you want to, look at specific things inside a hospital room and do that measurement? Do you want an overall measurement for one room? Do you want, right? And so, but there are all kinds of problems we need to solve that we might not be automatically collecting the data for. And that was just one example of, we really had to think about how to sample a room to get a good idea of how clean it was and where, your biggest problems are.
Mm-hmm. And do you find now that if there are cameras or other ambient kinds of devices, do you lean first on those kinds of ambient devices to help you with that data collection? Or do you lean first towards just human collection because first you have to understand what humans do and then you can do a little bit of automation?
Yeah, well, I think one of the problems with cameras is humans don't behave as naturally as they do when the cameras aren't present. That can be tricky right there. I think that the most important thing is really just understanding the problem you're solving. It might be them mapping out a process and then thinking about at what points does it make sense to collect data, and is that data already coming in, or is it something that I need to do by hand, by a stopwatch? Yeah, it really depends.
I'm glad you talked about that data collection part, because especially as digital collects so much data, we just think, of course, it's available. So with the last question, we've got about 45 seconds left. What do you see over the next 10 years that excites you about having more data or different kinds of data that will then impact your ability to do analytics?
Yeah, I'm excited with AI in general as an accelerator. If we're careful and thoughtful of how we use some of these new tools that are now available, we can actually solve problems faster. And so I am really excited about the potential with that.
So Cheryl, thank you so much for taking time out of your busy schedule here at HIMSS to share your insightful perspectives with us. We'll hope you come back and tell us more stories.
Yeah, thank you. This was fun.